Good afternoon, everybody. My name is Peter Clayton, and I'm the Clinical Director of the Manchester Academic Health Science Centre, and I'm very pleased to be chairing this afternoon's seminar. This is the 8th seminar in our series. We started these seminars in the summer so that we could showcase the great discoveries and clinical science that's being undertaken within Manchester and within the Academic Health Science Centre, and the impact that it has on the health of the local population and beyond. Manchester Academic Health Science Centre is part of Health Innovation Manchester. We have always asked our speakers to pitch their presentations towards a general audience, because we do have members of the public included within the audience. There has been a significant focus, not surprisingly, on COVID-related research, and this afternoon is no exception. So you can see that the title of the symposium is Understanding and Treating Suicidality, Pre and During COVID-19. And these seminars are recorded. They're also available simultaneously on the Health Innovation Manchester YouTube channel. So if you do know of somebody who would like to see the seminar and has missed it, you can point them in the direction of the recording. So I'm going to hand over now to Professor Gillian Haddock and her team, who will take you through their presentation. Jill.
Thank you very much, Peter. Okay, thanks very much, Peter. I'm really pleased to be here this afternoon to speak at this MAHSC seminar and to share the work that a whole team of us have been doing over several years, many years, in looking at trying to understand and treat suicidality. The last few months has obviously been challenging for everyone, and it's been challenging for us in relation to the work that we're doing. And what we're presenting this afternoon is some of the work that we've been doing and what impact COVID has had on the work that we've been doing in terms of suicidality generally and specifically on some of the clinical trials that we're working on at the moment. So we've got 4 speakers, and I'm going to hand over straight away to Professor Roger Webb, who is going to talk a little bit about some of the evidence in relation to how COVID has impacted on data relating to suicidality. And then we're going to talk more specifically around treatments for suicidality. So I'd just like to hand over to Roger.
Okay, thanks very much, Gillian, and then also Peter for inviting me to present at this seminar. So I'm going to talk about some early epidemiological evidence in relation to the impact of COVID-19. Can I have the next slide, please? Thanks. So before I talk about the impact on suicide and self-harm, I'd just like to talk more broadly about the impact on population mental health in the UK. And over the last 7 or 8 months, a large body of evidence has built up in relation to the impact on population mental health. And I'd like to just focus on these 3 examples. So there's a consistent pattern really that mental health has been adversely affected in the UK population. So the first example I'd like to present is this study that was conducted in the UK Household Longitudinal Study, Understanding Society, which was led from University of Manchester by Matthias Pearce and Catherine Abel. And in this study, it was a nationally representative sample across the UK. And what that study reported was quite a substantial rise in the prevalence of clinically significant levels of mental distress, rising up to 27% during April 2020 versus just 19% in the preceding years, 2018 to 19. And this level of increase across the entire population is very big in terms of absolute numbers of people affected. And we saw particularly large increases in women, in young people, and adults with preschool children. Now, in this second example, which was produced by the Office of National Statistics in their Opinions and Lifestyle Survey, this received lots of media coverage, and they reported an increase some form of depression, increasing from 1/10 of the population to 1/5 of the adult population during June 2020. I mean, this is a huge increase, and we have to perhaps be careful about this particular finding, because we'd want to be confident that the measure of depression before COVID-19 was equivalent to that after the pandemic started. But even so, it does indicate potentially a huge increase in prevalence in the population. And finally, there's this study led from Rory O'Connor's team at the University of Glasgow, and they showed a rise in suicidal ideation across 3 survey waves between March and May 2020. And again, this is a nationally representative sample. So it seems pretty clear that there's been an increase in the prevalence of psychological distress and mental illness in the population as a consequence of COVID-19. Now, the tricky thing is trying to assess whether that's led to an increase in risk of self-harm and suicidal behaviour. So we conducted a study in the CPRD. So this work was led by Matthew Carr and Sarah Steig, and other people involved included Nav Kapoor and Darren Ashcroft, and it's funded by the Greater Manchester Patient Safety Translational Research Centre. And this is a study conducted in 14 million patient records, nationally representative sample of all the primary care records in the UK. And what this shows, the yellow line is the predicted line. So these are the incident self-harm episodes that are recorded in primary care case notes. And the purple line is the actual observed value. And what we see is that after the lockdown on the 3rd week of March, there was this 38% fall in recorded incident self-harm episodes in the primary care record. And you'll see that over the last few months, the incidence rate has climbed up again back to more normal levels during the summer. Then it seems to have fallen away again during the autumn months. This paper was accepted by the Lancet Public Health today, actually, so we've got some good news to report there. But the issue here really is what's happened to all these incident episodes. We don't know whether it's a recording issue or whether people are harming themselves and not presenting to services. Next slide, please. And this result is from the same study. So here we stratified the temporal trends by deprivation level, across 5 levels of deprivation. And what this is showing is that the drop-off in recorded self-harm episodes is much greater for patients who are registered at the most deprived practices. So these are the patients who are registered practices as indicated by the grey line. That's the light grey line. That's the most deprived practices. And the bottom line, the black line, is the least deprived practices. So the drop-off in the recording of self-harm episodes was greatest for patients registered at the most deprived practices. Have the next slide, please. And this is just some snapshots of the kind of information that's reported in the media. So there's been lots of reporting in both the mainstream media and social media about COVID-19 suicide risk, and this has led to lots of heated discussions and arguments, really, especially on social media. There's been a lot of talk of an explosion in suicide and an epidemic, if you like, in suicide, but this is quite unhelpful because a lot of this discussion isn't around solid evidence. So this tweet by the London Ambulance Service, for example, has caused a lot of debate, and it's led to attempts to try and quantify the increase in the suicide rate. Can I have the next slide, please? Or an assessment of whether the suicide rate has in fact increased. So some colleagues at Bristol and Swansea universities and myself and Nav Kapoor at Manchester have been involved in a living systematic review, which is led by Anne John and David Connell. And what we've found since March, we've been looking at every single paper that's published around the world, looking at evidence of an association between COVID-19 and rates of self-harm and suicide in the population. And we found there's an absence of scientific evidence showing an increased risk since the pandemic began. Now, the problem is we can't really study suicide rates as yet because there's a 4 to 6 month time lag between suicide occurring and Her Majesty's coroner returning a suicide verdict. So we won't really know what the impact across the full calendar year has been until the middle of next year. So there's been various studies looking at real-time surveillance of probable suicide rates, and these have been conducted. So when we say a probable suicide, these are based on information basically that's available prior to the coroner making a determination. And there's been studies reported from England, Massachusetts, USA, and various Australian states, including Victoria, and they found no evidence of increased suicide rates during the spring and summer 2020. Some studies have even shown a fall in the early phases in Japan and Norway. Now, Japan is something of an outlier in terms of the current evidence base. It's the only developed country to have reported an increase in suicide rates during the autumn of 2020, and after an initial fall during the spring. And all of the increase, or virtually all of the increase that has been observed is among women and especially younger women. So there's been this 63% increase in younger women during the summer and autumn months. There's a much less clear picture emerging from lower income countries. Can I have the next slide, please? So to summarize the evidence that we have available so far, there's 3 key things to take home, I think. One is that prevalence of distress and mental illness have increased since COVID-19 began, with certain subgroups consistently found to have experienced especially marked deterioration. So these subgroups tend to be women, younger people, deprived people, and people who don't have access to good quality outdoor space. But having said that, we've seen a sharp decline in the frequency of self-harm episodes entered in healthcare records during the early phases of the emergency. We found that in the UK, and it's also been found in lots of other countries as well. There's also no evidence of an increase in suicide rates as yet over the spring and summer months and early autumn in the UK. And this is also true of virtually all other developed countries where real-time surveillance of whole population probable suicide rates is possible. Next slide, please, Jill. So there's an apparent anomaly here. We've got an increase in mental illness in the population, but no evidence of an increase in suicide risk. And why could this be? Well, the first thing is that prevalence of mental illness and suicide rates do sometimes diverge. So most surveys indicate higher prevalence of depression and anxiety disorders in women compared to men, but the male suicide rate is 3 times higher than in women. So that's a clear example of that divergence. During the early months of the COVID-19 crisis, some vulnerable people may have been protected from suicidality by heightened social cohesion, as evidenced through the Clap for Our Carers ritual every Thursday. Amongst others, there may have been a state of survival mode that was induced by fear, and that may have protected people from suicidal ideation. So the thing is, the impact of COVID-19 on suicide rates may take a considerable amount of time to transpire. And as the crisis continues way longer than most people had expected and hoped it would, then despair and hopelessness may become much more common in the population. And we know from previous recessions that suicide risk could well become an urgent concern in the longer term due to the economic fallout, which hasn't yet fully hit the population in the UK and elsewhere. Next slide, please, John. So I'd just like to end with a list of groups of people who have a particular kind of concern in relation to suicide risk and also non-fatal self-harm. And these could be priority topics for future research. So includes people living alone or those who are particularly socially isolated at the moment. We've got people who have pre-existing mental health problems or addictions. There's those who've developed mental health problems or addictions for the first time during this year. People who are trapped at home or with abusive or violent partners or parents. People who are experiencing deteriorating domestic relationships or they've become newly separated from their partner. People living without a garden or those with limited access to quality outdoor space. Those who are unemployed or whose livelihoods are in jeopardy. Those who've experienced particularly traumatic bereavements. So examples of that might be people who weren't able to see their loved ones when they were in ICU, and people who weren't able to attend, the funerals of people who are very close to them. We've got adults disengaged from the education system, also other youngsters who've become very much disconnected from their friends. Also frontline key workers who are burnt out or are experiencing PTSD. And then a final group is this specific group of survivors due to COVID-19 infection. So over the months and years to come, these are groups that we'd be particularly interested in studying to see if their risk of suicide and self-harm has increased. And that's it now. I'll hand back to Jill.
Okay, thanks very much, Roger. There's a bit of data for us, some hard data on the impact of COVID on suicide and self-harm. So I'm going to move on to talk about some of our specific work around delivering psychological treatments for suicide for people who we consider generally at most at risk, and how that's impacted on those people and that work both pre-COVID and post-COVID. So just to say a little bit about, Roger highlighted some of the key groups which are at risk in relation to suicide just generally. And what our focus of work on is generally about those people who are probably most at risk. So we do a series of trials aimed at understanding and treating suicide, usually funded by the National Institute of Health Research, or MAHSC. And what we tended to do is to focus on those most severe populations at risk of suicide. So people with severe mental health problems, such as schizophrenia, people who are resident on acute psychiatric wards, psychiatric inpatients, and people residing in prisons. And just to pick one of those, psychosis and suicide. So as many of you will know, psychosis is reasonably common in the general population, around about 2 to 3%. And of those people, between 20 and 40% will attempt suicide during their lifetime. And about 10% of those will die by suicide. And if not attempting suicide, many experience really distressing ongoing thoughts of suicide and self-harm. So this is a population that are really distressed and really troubled and may well end their lives by suicide. So a real priority for intervention. So we know the risk factors for suicide. We know the key risk factors such as demographics, various factors to do with gender or age or education, employment, and so on. And we know that having a history of previous suicidality is a risk factor for future suicidality, and having known mental health problems. But some of the limitations of knowing those risk factors or that epidemiological research is that many individuals who fall into what we might say are high-risk groups, actually, most of them don't kill themselves, they're false positives. And many who do kill themselves don't fall into high-risk groups. So it makes it very difficult to predict how people will respond on an individual basis. So in terms of how risk factors are used, they don't necessarily on their own help us to develop specific interventions for individuals. So for example, we can't change static risk factors such as gender or change historical factors, but we can do something to influence people's current psychological state and the current psychological factors that might be impacting on why they're suicidal. And that's really the focus of our work in developing a psychological therapy for suicidality. And we know they're effective. with lots of people in the community. And we know that actually the best evidence base is for one-to-one, face-to-face cognitive behavior therapy, a type of psychotherapy which is the largest evidence base. Obviously, face-to-face therapy has been a challenge during COVID, and that's something we're going to talk about. And cognitive behavior therapy is a treatment that's recommended by NICE, although the evidence is much more limited with those complex populations that we're trying to develop treatments for in our group. So the intervention itself, there's a very nice book which describes the intervention, a treatment manual. It's a one-to-one therapy, as I've said, usually delivered over, we offer it to people usually over 6 to 12 months. It usually comprises something like 20 to 25 sessions in total. That's usually for about an hour, usually delivered weekly, but it can be more than that or less than that, depending on people's needs. And what it does is to target the key psychological predictors of suicide. So those things that we can change. So the key factors that we have identified are about hopelessness, they're about entrapment, and they're about feelings of defeat. And there are things that we can do about that. And the intervention is really then focused on a very detailed formulation or understanding of the factors which contribute to their individual suicidal thoughts and acts, incorporating a real element of long-term recovery to enable us to reduce future risk. So to give you an example, or a pre-COVID example of one of our trials or intervention trials, just to give you an idea of the sorts of things that we're doing. So this is the INSIGHT trial funded by the National Institute of Health Research. It's a randomized controlled trial of that therapy, cognitive behavior therapy for suicide prevention, but delivered to people in acute inpatient settings. So why should we be focusing on people who are living in acute psychiatric wards? You might think that that's the best place for them to get treatment. Well, one of the reasons is suicidal behavior is really, really common in psychiatric wards, and about 10% of all completed deaths by suicide happen in those sorts of settings, unfortunately. Around 120 patient deaths from suicide every year just in England. And trying to help and treat suicidal inpatients is expensive. Of course, it's expensive financially, but that's, I guess, not the biggest issue. But personally, for individuals, for families, for carers, a suicide death has a huge impact on all areas of people's lives. And also because being admitted to an acute psychiatric inpatient unit indicates the highest possible risk for the individual, and they have the most complex problems. But suicidal inpatients have continuous 24-hour direct contact with services and staff. Therefore, they should be the most preventable of all suicides. The usual treatment for people residing in psychiatric inpatient units will be mainly about keeping people safe. So frequent risk assessments, observation, medication, containment in the sense of helping to keep people safe, one-to-one timed with a named nurse, ward activities or groups. But psychological therapies are generally not thought to be the place to be delivered in that setting, so are usually sparse or absent. So we want to change that environment. So the key questions we were asking: can we implement our cognitive behavioral suicide prevention therapy within that unusual setting? Is it feasible and acceptable to staff and patients, because we need it to be acceptable by both? And what impact might it have on, how long they're in hospital, how suicidal they are, their other mental health problems and so on. So just to go very quickly into whether it was feasible, well, the findings suggest it was feasible. I guess I wouldn't be talking about it now if we didn't find that it was. It was a small trial, 70 people. And roughly people tolerated, and I mean tolerated in the sense that they accepted and were able to engage in up to 12 hourly sessions of the therapy whilst on the ward, although the range was pretty wide, with some people wanting a lot and some people not wanting very much. This graph sort of tries to illustrate that for you. Was it acceptable? Yeah, so for the people that were involved, for the service users, we did a load of qualitative work, lots of interviews with people to really get a feel for whether they liked the intervention, whether they wanted it. And it was very, very clear that they really valued having the opportunity, even when they were feeling at their worst, to discuss and talk with someone in a lot of detail in the way that we wanted to do it in this therapy. As I've said, the data on the take-up of sessions was good. And also people were able to engage very well in therapy. They were able to engage in the therapy in just the same way as they would if they were living in the community. We measured something called therapeutic alliance, and it was very similar to that we found in other studies. Staff also found it fairly acceptable. It was generally well received. The delivery of the therapy wasn't too disruptive to other ward routines, and crucially, I think didn't seem to make people worse. Talking about suicide doesn't make people worse, which I think is some of the anxieties sometimes from staff and for people taking part. But we did find one of the things we have to measure in trials is what's called serious adverse events. So these are adverse events that happen within the trial that are monitored at all times to check that whatever we're doing with a new intervention is not harmful to people. And as you can imagine, in a trial looking at suicidality, serious adverse events were very common. And we recorded just in that short time period 255 serious adverse events. And these are events which involve serious self-harm or risk of death. And some people had none and some people had a lot of events, so it varied quite a lot. Crucially though, none were related to us delivering the research or delivering the therapy. They were no more frequent in the therapy group compared to the treatment as usual group, suggesting engagement in the intervention does not at all increase risk. So what can we conclude about this sort of intervention in this environment? Inpatients are a high risk group for suicide, of course, we know that. But actually inpatient stays crucially offer a rare opportunity for your engagement in psychotherapy rather than waiting until the community. And it's feasible, acceptable, and it's not harmful either. So the final question we had at the end of that was, can we roll this out more generally for these people who are, I guess, the most seriously at risk of suicide? So this led us on to what is our current trial, which is the CALMS trial, which is short for Cognitive Approaches to Remediating Suicidality, funded by the Medical Research Council. And what we did was to take what we learned from Insight to working with people with schizophrenia living in the community. It was delivered all over Greater Manchester, up as far as Lancaster, across to Ashton-under-Lyne, Northwest Boroughs, Wigan, Warrington, and so on. So over quite a big area. And things were going brilliantly in terms of recruitment into the project. We had 233 people in the project in March 2020. Our final target was 295, and that was planned for the end of July 2020. But of course, COVID hit in March and lockdown hit. And we had to pause recruitment for safety reasons for 4 months due to COVID. However, we still had patients in the trial. We were still treating people. They were in therapy. They were a very high risk group. So we just had to continue somehow. We couldn't go into full lockdown when we were working with such high risk patients. So I am just going to finish there, and Dr. Yvonne Auernat is going to talk a little bit about how we manage the research staff and participant safety during COVID. Dan is then going to go on and talk about therapy, and I'm going to wind up at the end. So I'd just like to hand over to Yvonne.
Thank you, Jill. So I'll say a little bit about how the COVID restrictions regarding social distancing impacted on us conducting the actual research. Next slide, please. So all the participants in all of our suicide psychological therapy studies will be either having the therapy or they'll be in a group of people who will carry on with the usual treatment they were having without the therapy on top of that. So it's a lot of people who are in the trials, and we had to then find a way of continuing to work with them without the possibility of seeing people in person, which was our preferred and usual way of working with people. everybody would have interviews with the research assistant at the start of their involvement in the trial, and then periodically midway and towards the end, so that we can get a feel for whether people are finding benefit from the study, from the intervention, or whether they're not, carrying on as usual. So this meant we had to look at a whole new way of delivering our research interviews. And from having in-person contact with individuals, research assistants that they probably got to know fairly well, we had to move to more remote, usually phone methods of conducting assessments. And these assessments would comprise of asking people a lot of questions about all kinds of areas of their life, how they were feeling psychologically, things they were doing in their life, and the impact of the therapy, if they were indeed having the therapy. So remembering that all these participants had either a history of feeling suicidal and of self-harm behaviour, or they were actively suicidal at that time. That was a basic eligibility requirement for being in our studies. So they were all high-risk people, and the training and procedures that we had in place for our research staff were geared towards that kind of interaction. So it meant that we had to change a lot of these regulations, a lot of these processes and procedures to how we would monitor and make sure people are kept safe, and of course keeping our research staff safe as well, with not face-to-face but remote, usually phone interactions. And identifying risk in people is very, very important, because at its worst that could mean that we have to review what's happening in therapy if they were having therapy, or alert their usual clinicians if they were having the usual treatment. So the lack of face-to-face contact does remove a lot of our usual, very familiar ways of identifying whether people are feeling distressed, whether they are at risk of self-harm or even suicide. Next slide, please. So from the usual things that we would train research staff in being able to be alert to pick up, for example, somebody might be looking sad. If you could look at their facial expression, their eye contact might be more intense, or it might be rather missing in terms of engaging with somebody. We'd look at how people are presenting in terms of their body language, whether they're feeling sort of quite tight and rigid, or whether they're more, as we all are, just having usual body language. We look for signs of agitation, and if we're in a room with somebody, we can monitor whether they are agitated, moving around, fast pacing, hand wringing, and we look at general evidence of their physical appearance, whether they appear to be rather not looking after themselves too well, evidence of poor hygiene, weight loss, and the environmental level as well. If you're going into somebody's home, which would have been quite the usual way that we would be working with them for the research assessments, we could easily pick up signs of neglect in a more broader sense environmentally. For example, lots of unopened posts. Next slide, please. So we had to change the kind of things we were training our staff to be aware of, from the things that would easily be picked up in person to things that could only be picked up during a phone conversation. So this meant that we were having to explain about the difference in being more astute to pick up differences in the tone of voice, for example. Sometimes people who are experiencing distress might be very quiet and not engaging very well in verbal communication, or they could be very loud and angry and highly excitable, or just maybe a kind of general monotone, showing a kind of level of disinterest and unable to engage. And then we have certain ways of looking at the pattern of speech, whether it's sort of like giving very almost reserved and stunted answers to questions, whether there is just one-word answers, whereas previously the person might have been a little bit more verbal and engaging in what they were saying, whether people are showing signs of being hesitant to answer anything, long silences, or in fact whether it's more hurried and a little bit chaotic in pattern. And then there was the non-linguistic sounds that you can pick up audibly, even if you aren't seeing somebody in person. You can usually pick up if somebody is crying, or if they're, sort of having exasperated, sighing, sort of laboured breathing sounds. There are kind of repetitive single cough that some of us term a kind of nervous cough. We also could explain about the noticing the content of speech, whether that person appears to be a little bit muddled or confused, maybe not quite getting the question that we're asking, whether their responses are in fact quite incomprehensible, whether they're becoming even quite angry and aggressive, or whether they're repeating information that might indicate that they're a little bit confused, their recall isn't great. Or the other thing is that we have to be, when you're in person with somebody, you can much better pick up whether things are going on that are really quite threatening to the individual. Sometimes people are living in, Roger mentioned about the increasing in domestic violence when people are all, cooped up together in an unnatural situation and very little release from each other with poor relationships. So we had to kind of plan for what will happen if we're talking to the participant and they suddenly stop. What does that mean? Does it mean they're just fed up with the interview, or could it mean something more serious? So we had to, have a plan really for what we'd do if there was an unplanned cessation to the phone call. Next slide, please. So that's more difficult to judge. And we had to sort of have a code whereby when we were talking to people about arranging the interview, we would remind them of the need to have somewhere where they can speak in private, and agreeing a code word for somebody comes into the room, you don't feel comfortable speaking in front of them. So that was something we did set up in advance, and what we should do if actually phone contact was lost. Some people were happy to give us an alternative phone call to phone, some people weren't. So next slide, please. So these were all the ways that we tried to empower our research staff to be more aware of how to keep people safe. Thank you. I'll hand over to Jill now.
Thanks very much, Yvonne. So I'm just going to quickly move on then to Dr. Dan Pratt, who's going to talk a little bit about how we had to modify the therapy delivery during COVID.
Thanks, Jill. So I'm going to briefly offer a few reflections that have emerged from predominantly from the CALMS trial that Jill briefly mentioned earlier. CALMS trial was halfway through, or over halfway through really, but we were continuing with the CALMS trial as we started to move towards a different form of offering therapy away from face-to-face. Okay, thanks, Joe. So there was a required transition away from face-to-face delivery, the typical setting for a therapy, to more remote forms of delivery. And when I say remote, I'm talking about telephone-based sessions, or maybe Zoom-based sessions, or Teams-based, or video-based sessions. And I think initially, certainly in the early days when we were beginning to relaunch the therapy, there was an experience of challenge in regards to the transition. We had to offer an explanation to the clients, to the participants that were currently in receipt of therapy, and offer them an explanation as to why we were moving to remote delivery. Many of the clients came with us, a vast majority of the clients understood that there was a need to move across to remote delivery, and they came with us. There was some reluctance, some hesitancy, and I'll unpick that a little bit more as we go along. The initial concerns held by therapists echoed in no small part what Yvonne was just been saying. How, from the therapist's point of view, how should we manage these difficult conversations remotely? It felt as though a lot of the information that a clinician would want to draw upon when making a risk assessment is not available to that individual anymore. Certainly if it's a phone session, the non-verbal information would go no small part. It would be quite a substantial piece of information for therapists to rely upon. That wasn't available. And then similarly, how should we, as the therapy team, how should we successfully engage with participants' care teams as well? How should we go about sharing information in a meaningful way that would typically be done face-to-face? So there were some apprehensions, there were some challenges for us to get our heads around. And there were also some technical challenges as well. The need to get familiar with Zoom. I'm sure we've all gone through this a little bit over the past 6 months or so. To become more familiar with Zoom or Teams, we had a range of platforms that were potentially available. And each of these platforms bring with them some advantages, but also some disadvantages. So there was a number of challenges to be raised there. And then also different levels of confidentiality. If we're delivering telephone-based therapy sessions, it's not easy to work out who else is within earshot of the client how much confidential space is available to the client at this time, whether we could record the sessions, which we'd want to do routinely. So a number of technical questions to be asked as well. So there were some anxieties around moving to remote therapy. There were some concerns around whether or not the quality of the interaction between the therapist and the client would be good enough once we moved to remote therapy. But I think upon reflection, I think we realised that yes, actually, we could probably tolerate the slight drop in quality when moving across to remote delivery. But there was sufficient content and quality within the interactions, within the sessions with clients to make it worthwhile continuing. So there was definite value attached to continuing to offer telephone or video sessions to clients. It was better to try and resolve the challenges that we were coming across than not to. The majority of the clients, to my surprise, preferred telephone delivery rather than video conferencing. And that still remains the case now, even 6 months into remote working. Most people prefer to have telephone-based sessions rather than Zoom or Teams-based sessions. That does offer us a challenge. There's no visual information obviously available on telephone. That's difficult to then do more visual work with clients. We might want to work with a client to develop a formulation or an understanding of what's happening to them when they're feeling particularly suicidal. And we might want to do that using more visual means rather than just relying on our verbal information. And yet, when we're on the phone, that's all we've got. So that we require the therapy team to be quite creative and innovative in the way that was achieved. Perhaps most importantly, I don't think we noticed any significant impact upon engagement. So what I mean by engagement is, were clients wanting to meet with their therapist as much as prior to COVID? Were the clients actively involved in the therapy work as much post-COVID as pre-COVID? Yes, actually. There was no noticeable decrease in our attendance rates. Our did not attend or cancellations have not noticeably increased. We've often found when we're offering therapy to suicidal clients, that's very much an unmet need. And so there is a real desire for the clients that we meet to have this conversation. And that desire, I don't think, was lessened, or there was no evidence to support it being lessened since COVID. Our engagement levels was pretty much the same. So very briefly, to summarise, some advantages of remote delivery, definitely. Far less travel for our therapists. Jill mentioned before for CALMS that the reach of CALMS is pretty much across almost the whole of the Northwest. And the advantage of telephone or video-based sessions is there is no travel requirement there. So maybe that offers our therapy team more opportunity to meet with more clients, potentially. There's certainly more flexibility and arguably more accessibility for clients. We can now offer therapy or access to therapy from the client's home, if that's where they choose to be when they take the phone call or the video call. The telephone therapy sessions appear to be more focused as well. Our typical 50-minute hour of a session telephone sessions tend not to need to be quite that long. Perhaps we can cover the ground we need to in 30 to 40 minutes now, maybe. But there are some disadvantages, and we're not overlooking the importance of these either. I've mentioned already, telephone sessions don't offer us the non-verbals, the body language, and I think that is a significant loss that we need to consider. There are silences within therapy sessions. You would expect that to happen. The challenge or the difficulty for a therapist is how to interpret them. Is the long pause appropriate? The client is thinking. We've provoked them into having some decent reflection upon their difficulties. Is the client crying? Is there a risk issue emerging here? That's much more difficult to spot, I think. And then certainly for our newer clients that we started therapy with during COVID, maybe the therapist has never actually met the person face to face, and maybe there's no image of the client either. And I think that can sometimes be challenging for therapists as well. We found it much easier to maintain engagement and to keep going with the therapy if we can actually visualize an image of the client. And so maybe if we could offer a picture of the client to the therapist and a picture of the therapist to the client, maybe that would overcome that to some extent. And then there's that last question, primarily around confidentiality. Who else is present in the therapy room? And maybe the client isn't on their own. Maybe they can't be on their own for whatever reason. And so how can we ensure that there is sufficient confidentiality being offered, sufficient privacy being offered to the client? Because we're going to ask them and need to ask them some quite difficult and intimate questions when focused upon suicide prevention. So challenges, advantages and disadvantages. Okay, let me hand you over to Jill then. Thanks very much.
Thanks very much, Dan. So I guess you've got an impression that our delivery of suicide interventions for people, I guess, who are in the most high risk group in relation to severe mental illness, we managed to keep things going through COVID and actually had some nice surprises in some ways, as Dan mentioned, in terms of the advantages of delivering therapy that way, which probably as clinicians, that was a little bit of a surprise because we thought everything, ought to be face-to-face, and it's much better being face-to-face. So I think there is some positive that's come out of this particular issue, as well as some of the difficulties that we've come across as well. So just to finish off very quickly, what difference does it make in terms of the trial? So remember I said we'd recruited up until March, then we hit lockdown. I am very pleased to say that we hit our recruitment target of 295 in the trial on Monday this week, and that's the number we need, which is fantastic. So whatever has been happening over the last few months, we have been able to keep recruiting. People are still wanting the therapy, and we've been able to deliver that, which has been really positive. Similarly, in terms of following up people for the project, we've still been able to do that as well. And I've been amazed at how fantastic the participants in the trial have been in keeping in touch and wanting to keep in touch with us and in receiving the therapy. And I guess what I wanted to mention was, did it make any difference in terms of the self-harm, the suicide attempts in our sample as COVID hit? And what we found is that our occurrence of serious adverse events hasn't increased during lockdown in this sample at the moment. But it's certainly true that many patients in the trial, many of the people we're working with, really do find the isolation hard, as all of us does. It can exacerbate loneliness, it can exacerbate some of those key things that are associated with suicide. That feeling of being trapped, of being defeated, the depression, the anxiety, there's no doubt about that. However, for some people, it wasn't all negative. Some people preferred to the isolation a little bit and reported finding that lockdown made life easier for them, because facing people was one of the difficulties that they had. So for example, maybe someone who was very paranoid found it easier not to be forced to engage with other people. So the response was very mixed. But I think, as Roger really highlighted at the beginning, the long-term impact of COVID is unknown on mental health, and it's certainly unknown on this sample, those people with the most severe mental health difficulties. So our data collection really has to be ongoing for us to see the longer term effects of this. Thank you very much for listening. And I guess we're now in a position where we can take questions.
Right. Thank you very much indeed, Jill and Roger, Yvonne and Dan. That was great and really clear and very instructive around understanding how you delivered your trial. And I think in my own clinical practice in endocrinology and pediatrics, we've found quite a few children, for instance, with autism, have actually done rather better during the lockdown because they haven't had as many stresses in their lives. So it resonated with the comment you made. We had one question that came in while Roger was talking, so I'll just read that out. And then I think we've got a series of questions that were sent in before, which we'll work our way through. We can go a little over 4:30 if we need to. So let me read out the first one, which was from Kay Barker. Does the data, and this is, I think, aimed at you, Roger, does the data take into account people residing in specialist mental health facilities or care homes, or is this based on data from the community? Okay, so
I presume this question relates to the trends in the incident self-harm episodes that are reported as recorded in primary care records. So essentially, these data were extracted from a nationally representative data set of all GP registered patients, and the self-harm episodes essentially are just entered into the record, and they pertain to all people who are registered at a given general practice. So we didn't have any specific indicators of the populations that you're referring to in that data set. This pertains to the entire general population.
Right, great. Thank you, Roger. Moving on, and perhaps if I read them out, Jill, and then you could hand them round your team.
Okay, yeah, no problem.
If there are, are the findings by social deprivation levels and ethnic backgrounds?
I think that's one for you, Roger.
Yeah. Okay. So a lot has been said about the impact of COVID-19 on so-called BAME groups, Black and Asian minority groups, and lots of things have also been said about the impact on more deprived communities. So basically, we know that the rates of contracting COVID-19 and getting seriously ill and dying from it were higher in non-white ethnic groups, and we also know that the age standardized mortality rates for COVID-19 are higher in more deprived communities. But I suppose our interest from a mental health perspective is how, whether there's been a differential impact on the mental health of more deprived populations and non-white ethnic minority groups. And as yet, we don't really know the answer to that question because such data sets are not yet available. They will be available in the future. I mean, one of the slides that I presented showed the recorded episodes of self-harm, and the drop in April was across the board, but it was greatest in the most deprived general practices, the practices with the most deprived communities. So at the moment, we don't know what the consequence of that is, but we can only speculate, and it's probably likely that the greater the level of unmet need in a population, the greater the adverse consequences over time. So if more people with a need for mental health services have stopped engaging with services in the most deprived areas, then the likelihood is that there'll be a greater number of people with unmet needs and with more serious untreated problems in those communities. I mean, a lot of this is speculation rather than what we can actually see in the data, but I think everything points toward certainly the most deprived groups being affected, disproportionately, and also ethnic minority groups as well. But we should be careful there because much of the higher risk in many ethnic minority people is often explained by deprivation. So the two things are intertwined.
Right, thank you. And the next one is about sort of urgent management. And this is what to do in a situation where a patient mentions they'll go home and commit suicide.
Okay. Well, this is something that we come across probably every day. Yvonne, is that one you want to cover?
You're on mute, Yvonne. On mute.
Okay, am I wide for sound? Yeah. Yes, well, it is something we come across frequently, and the people that we, engage with are already engaged with mental health services. So for us, it's a little bit easier because we know who the normal clinicians are, and we ensure that they are alerted, and depending on how serious and imminent the risk is assessed to be, we may put them in touch with their clinicians. We may, to the worst extreme, end up calling an ambulance or going with them to an A&E department or taking them to the mental health unit. But if it's not a person in our participant group, then there are a whole range of things, and we make available to people a big list of ongoing resources, because sometimes people appear to be okay after we've engaged with them, but so they can start thinking about things, and sometimes in the evening, over the weekend, things can get a little bit more difficult. So we make available to people a whole range of services like Samaritans, which is 24 hours a day, and it's completely anonymous and confidential. The A&E department, very often people involved with mental health services already have access to a 24-hour helpline for support. Otherwise, there's the GP, and there are taking someone straight to a hospital. So it depends on that person's own perceptions of how serious things might be, whether they feel they can keep themselves safe before they see their clinician next time. But the emergency services of A&E and of, in the worst extreme cases, calling an ambulance or even calling the police, there's a whole range of things available depending on how imminent and how serious it appears to be.
Okay, thanks very much, Yvonne. The next one is a very general question, important question. Could we discuss the key differences of suicide presentation between children and adults?
Okay, shall I do this one? Well, we don't work with children in our work with suicide, but I guess we obviously have a knowledge of presentation in children and in adults, and presentation does tend to differ a little bit with children's mental health problems. They may be less likely to directly discuss their difficulties in the same way, so they may present more in terms of particular behaviours, what you might call externalizing type behaviours. So it might be in terms of being more irritable or being more aggressive or having difficulties with school and those sorts of things. There does seem to be some evidence that children who may be thinking around suicide and death may be more preoccupied by death or looking at more sites, mobile sites and things like that with regard to self-harm and suicide. So those are some of the, I guess, general things that I can mention, whereas adults may be more likely to communicate their distress more directly. I don't know whether any of the rest of the team would like to add anything to that.
I think the only thing I would add to that, I suppose, is the kind of expression of suicidal ideation might be less clear with a younger age group, I may expect. The expression of suicidal ideation may be difficult for adults, let alone children, being able to articulate the distress that a person is experiencing. We've certainly worked with a number of individuals that perhaps because of background, because of upbringing, they've really struggled to articulate, put into words why they are feeling suicidal or why they are distressed to the point that suicide is becoming an option to them. I could only assume, but it's a bit of a guess, that difficult putting feelings into words might be experienced just as much in younger people, maybe even more so. We know that the rates of suicide in younger people are much lower than adults. But we also know that the rates of self-harm in adolescents are quite high. So there probably is something specific going on in younger adults, adolescents, I guess. But as Jill says, we haven't done trials in that group yet, actually.
Right, okay, thanks for those comments. The next one is a general one as well, and I think it's probably related to sort of general management. So what are the recommendations for the post-COVID-19 era? If we ever get to a post.
Well, exactly. Well, I guess some of the things that we found to be positive out of the during COVID era, I guess, I think for me and probably for all of us as researchers and clinicians, that I would be thinking about being much more flexible about how we deliver psychological therapies, how we recruit people into trials. We've developed methods of, interacting with people, delivering therapy that we've had to do really quickly, really rapidly. And actually, we found that it's been quite successful. And a lot of participants like it. They would be much happier talking on the phone, not having to bother getting dressed or get ready for the appointment or go somewhere for the appointment. So some people have really seen the advantage of it. And I think it's really telling that we haven't lost many people in the therapy because of it. I mean, the people who've not wanted to do it because it's not face-to-face have been an absolute handful. And that's been a bit of a revelation, actually. So I think what we need to do is focus on how we can, continue to deliver flexible therapies. So not assume that everybody needs or wants face-to-face therapy and to be able to offer it in a range of different ways, whether that's in the context of a service or a trial. So looking more around the digital delivery of things, the sort of non-face-to-face delivery, I think it's got to be the way to go with all of this.
Great, thank you. Now, there are a couple more questions. We're actually at past, but if we could do the last couple of questions, perhaps with quick answers. The next one is an international one, and I don't know, it might be Roger in your territory. So the numbers of suicides in Japan in October exceeded the number of deaths from COVID-19. There are voices in the Weibo comment area, I don't know whether that's community area, that the number of suicides in China will also rise. May I ask if you followed this news and do you have any opinions?
Okay, I did follow the news from Japan actually. I noticed that figure, that the person who put the question about more COVID deaths, possibly more suicides occurring in October than COVID deaths in Japan, that was reported on CNN. I noticed that. I haven't been aware of the latest report from China, one of the Chinese provinces. I mean, we're doing our best to try and track all of this information as it's reported from around the world. But one of the issues I'd like to just mention is the quality of some of the evidence. So we're with colleagues in Bristol and Swansea conducting what we call a living systematic review, where we try and capture all of the evidence as it's published. And a large quantity of what's published is not high quality evidence, unfortunately. So we just need to be a bit careful, because some of this stuff can get reported in quite prominent media outlets, and it's not really very high quality information. And then of course this drives this furious debate on Twitter and other social media platforms about the impact of lockdowns and this kind of thing. So there is quite strong evidence emerging from Japan, I think, of a sharp rise in female suicides, particularly in younger females, in August and September. I don't know about the latest evidence coming from China. That might be something we need to look at a little.
Yeah. And is there a sort of international consortium that's keeping an eye on this?
Yes, there is. So David Gunnell at Bristol leads an international, I can't remember the full title of the consortium, but there is a international suicide prevention consortium which is aimed specifically at the impact of COVID-19.
Great, thank you. We've got one more question. Oh, sorry.
So just one final thing, Peter. I mean, the problem is we'll know probably toward the end of next year what the full impact has been in terms of suicide rates. But unfortunately, it's quite difficult to say right now what the true impact is.
Great, thank you. So we've got one last question, and I think it's an important one, so we'll go over the time a bit more. Do you have simple tools to help debrief staff at their end of their day around feelings and signposting appropriately?
Well, it's probably a really good thing to end on, because I think through all of our work, we've become aware of what it is like as a carer or a member of staff or someone working in this field. And, you know, not only is this a horrendous field for the individual, for their families, but it also is when you're a member of staff working in an environment which is so distressing. So we absolutely recognise this, and Yvonne's done some great qualitative work around staff and their experiences. And yes, we do have tools about debriefing. We train our researchers and our therapists about debriefing for patients, for themselves, and about self-care and well-being for themselves. So yes, in general we do, and I think it's a really important area. Yvonne, anything you want to add to that?
No, just to say that in our own department, James Lee, who I think is here today, has produced an amazing range of resources which, you know, are freely available to share. And just another point, that one of the questions that we didn't take was about the increase in female nurses' suicide. And, you know, nursing is can be a very stressful job. And the interesting thing there is that when compared to male nurses, the ratio is reversed, whereas there are 3/4 of the gender population of males that kill themselves and only 1/4 female. With the nursing population, then it's actually a higher proportion of female nurses than male. And maybe the idea is there that it's a stressful job, and the people who the studies have been done on, Horton's done quite a few in Denmark and in UK, and it shows that very often there are lots of potential quite serious psychological problems already underway. And then with the access to means that nurses have, with direct access to drugs, we don't really know the reasons why, but, you know, it needs more research. But certainly female nurses do show a higher proportion of suicide than male nurses.
Thanks, Yvonne. And somebody just put in the chat what an important point that was you've raised. So thank you. I think we should call it to a halt now. Thank you to the four of you very much for your extremely clear presentations on a very interesting area. Thank you for answering the questions, and for all of you out there who we can't see, but we can see your names, thanks for putting those questions in for us. And lastly, Jane, thanks very much for keeping us in control and taking us through how we do this meeting. So thanks, Jane. So we'll leave it there. It's available. The talk or the talks, the whole session is available on YouTube on the Health Deprivation Manchester channel. So do have a look at it. Tell your colleagues about it, and we will see you again in a few weeks' time. I think we may have one more before Christmas, and then we'll start again in the new year. So thanks everybody very much. Have a good evening.
Thanks all. Thanks, Peter. Thanks, Jane. Thanks to everyone.